It is 1 o'clock and we want to be respectful of everybody's time. Thank you, community, for joining us on Facebook Live for our first Facebook Live outreach event. We are members of the Philippine Medical Association of Hawaii, PMAH. We were founded in 1978, and we are doctors of Filipino and non-Filipino descent who take care of Hawaii's communities. Our goal today is to educate you, the community, the non-medical general community, about us, about your community, from your local doctors to raise awareness of what's going on with Hawaii. COVID-19 is a hot topic, and many of our PMAH doctors are considered frontliners. ICU and bed space are big determinants of the state's healthcare capacity. So our goal today is to speak to you on what hospital care is and with special regards to COVID-19. And just a disclaimer, these opinions are our own and not representing a major hospital system. We will be collecting questions from the audience via Facebook Live. So go ahead and type in the comment section and we'll try to get it at the end of our segments. Please feel free to press share button on the bottom so you can post this on your page, on your personal pages, so your family members and friends can enjoy this too. Okay, so we are going to start. Okay, so first up, I wanted to introduce our members that will be speaking today. Dr. Emilio Ganitano, let's wave. Hello, hello. So Dr. Ganitano, he is an ICU intensivist. He hails from Waipahu and Aiea. He went to St. Louis, did his education at Notre Dame, Jabsum, UH, and University of Pittsburgh for his critical specialty. And his family has some medical people in it. And then we have Dr. Mark Valdez, wave. He also hails from Kalihi, and he went to Damien, went to Jabsum, did his training in LA County, USC, and has been a physician for 5 years. His family also has some nurses and some nurses' aides. And he's also a critical care intensivist. And we are last minute addition, but very grateful to have him, our token white guy of the panel, Dr. Richard Kline. Dr. Richard Kline hails from Philly and went to inner city high school, actually. He did his residency in medicine in Washington, in the University of Washington, was an ER doc for a couple years in Washington, and has been here in Hawaii for 3 years as he has family that practices here. He takes care of many of our mutual patients, and he has, and our patients love him. So thank you for being here with us. He's a hospitalist, and he takes care of our loved ones that are in the hospital. And he does take care of several COVID patients in the hospital. So let's start. Okay, the basics. So I have no medical people in my family. My parents are not in the medical field, and the rest of my family's not in the medical field. I'm the first doctor, and I'm surrounded by non-doctors, and I grew up with non-doctors. And I don't think people exactly know what I do on a daily basis, because I think the general public thinks all doctors are created equal, but they're not. So let's start with the basics. Dr. Ganitano and Dr. Valdez, what is an ICU doctor and what is an ICU?
First of all, I want to thank you for inviting me to share my experiences. So thank you very much. So I guess the easiest way to kind of think of what the ICU is people get sick by varying degrees. So take something like pneumonia. Sometimes people who have pneumonia, they feel kind of lousy, but they're breathing okay. And doctors can treat them with just, oral antibiotics, and you can just stay home for that. Other people get a little bit sicker than that. So say like they can't breathe as well. Their vital signs are a little bit off. They need to be kind of monitored a little more closely. So then those people end up getting admitted into the hospital into like either what we call like a med-surg unit or a telemetry unit. And there we can give patients, things like oxygen, give them antibiotics through IVs instead of orally. And, nurses check in on you every couple hours or so. Doctors check in on you every couple hours or so as well. And then there's the other extreme where patients are really sick, like they're almost dying. They can't breathe even though we have oxygen on them. Their blood pressure is low. They need extra medicines for that. Those patients end up coming to the ICU. So ICU basically stands for intensive care unit. So obviously they're very sick, they're near death, their care is very intense, for lack of a better word. So those patients tend to be, attached to a breathing machine through a breathing tube in their mouth. They're on medicine to kind of help their blood pressure stay up. They're on IV antibiotics. And obviously, because there's this constant threat to their life, nurses can't be, checking in every couple hours or so. They need to be there pretty much 24/7, just kind of watching because things can change so rapidly. So that's kind of where the ICU comes in. Nurses are just kind of constantly always checking in on you. Me and Dr. Ganitano have specialized in that. So a lot of doctors will do kind of general training, internal medicine, anesthesia, emergency medicine, kind of general things, but then they take an extra 2 to 3 years to specialize in taking care of patients that need such intense care. So that's where our title intensivists come in. And then on top of that, the nurses too, like you can't just take a nurse who's trained in the med surg or telemetry area to take care of an ICU patient. There's a lot of things going on. So nurses also need to get special training to become an ICU nurse as well. So there's a lot of things that go into kind of that intensive care stuff.
Great. How long does it take to become an ICU doctor?
It kind of depends where you want to go, but generally speaking, so if you count the 4 years of med school, plus the 3 to 4 or 5 years of general practice, and then the 2 to 3 years of specialized practice, that equates to anywhere between like 10 years roughly.
At
a long
least,
time.
Right?
It's a long, yeah, it's at least
time.
10 years. Yeah.
A long road ahead.
Yeah.
Okay. Well, in the news and in the reporting numbers every day, Josh Green's numbers, the news's numbers, the online numbers, we always talk about ICU bed space and ICUs. And it's been a hot topic in the last week or so about how Hawaii's ICUs are becoming very full. Why is the ICU such a big deal in these COVID reporting numbers? Dr. Ganitano, you want to take that?
Yeah, sure. I mean, I think the important thing to think about in terms of COVID is that fortunately not a lot of the patients with COVID-19 who get admitted to the hospital need an ICU. However, when they do come to the ICU, as we'll talk about later, they require a lot of care. And although the Lieutenant Governor talks about the total numbers of ICU beds that are available, he usually is talking about what's considered space. So there's a certain number of beds in each hospital that's an ICU bed, and we have a certain number of beds total in the community. But what he doesn't take into account is, do we have enough equipment, specialized equipment like breathing machines and IV pumps to provide special medications to supply all those beds? And more importantly, do we have enough physicians with the type of training that Dr. Valdez talked about? And what's probably the more important part is, do we have enough nurses to staff all those beds? So although there's a certain number of beds available, do we really have the number of people to staff all those beds? Because patients with COVID-19 require a lot of help in the ICU. The traditional model we have for the number of nurses needed per patient changes. So we may not have enough beds to take care of these really sick people. And the other part of it too is, you may report the total number of beds, but as we're seeing now in the community, we have certain hospitals on Oahu where one hospital may not have that many ICU patients, but the hospital down the street has overwhelming number of patients. So it doesn't really talk about how that's distributed. So one hospital system could be really in a lot of stress and really, at the point of near breaking, whereas other hospitals may not be there. So how do we as a community fix that problem? So that's why it's important to have ICU beds, but more importantly, sometimes the numbers they talk to you about on TV doesn't really expose the real problem.
Okay, it's kind of scary because I know, you know, I wear many hats and we talk about inter-system transfers and things like that, and I still don't get it, how we distribute patients. But important thing is we need to keep these numbers low. Okay, well, how about, you know, we described what an ICU doctor does. We described how an ICU patient looks like. What's the difference between a regular ICU, sick ICU patient and a COVID ICU patient? Is there a big difference?
Yeah, so COVID ICU patients are just like your regular ICU patients in that they need a lot of intense care to take care of them. So typically with COVID patients, they're attached to a breathing machine. They're on different medicines to help with their blood pressure. Some of them are even attached to, you know, dialysis machines. So a lot of times the nurses have to kind of go in and out of the room to kind of reassess everything and change medicines and this, that, and the other thing. The trick with COVID-19 is it's a really contagious disease. So for example, we get like heart attacks and strokes in our ICU all the time. And if I walk into a room with a stroke patient, it's not like I can take that stroke.
You're going to get a stroke.
Yeah, I'm not going to get a stroke. Hopefully
Right.
don't. But I can't take the stroke and then give it to somebody else, like to the guy next door. With
Right.
COVID-19, it's totally different story. I mean, I go into a room, there's a chance that I could take that disease and give it to somebody else inadvertently. So the biggest thing that kind of changes between COVID and non-COVID patients is just that isolation that we have to do. So then we gown up, we hear like PPE all over the place. So personal protective equipment. So that's like your gown, your gloves, your face shield, your eye goggles, and then your N95 mask. Some people wear hairnets and foot coverings too. I mean, people get crazy with that sometimes, but you know, it's all for the safety of our patients. But I mean, donning all that stuff on just to take care of one patient just kind of puts that much more stress on the system. But again, it's all for.
I'm sorry to interrupt. Can you reuse these gowns and things, or is it like one use only?
They're one use only, the gowns and the gloves. We've been at least cleaning like the face shields, the N95 masks too. We try to recycle as well. At least the different hospitals have. But yeah, so then it's pretty much that whole trying to isolate the virus in that room is kind of the biggest difference between the COVID and non-COVID. And the thing about the rooms too, the rooms themselves are specialized. So every time we open the door, the pressure in the room is negative relative to outside. So any air that's inside that room doesn't have a chance to come out. So it keeps all that air in. And those rooms are actually, not all rooms are made that way. So that's another, I guess we didn't really talk about that, but that's another kind of resource that's limited in this pandemic.
Okay, good to know. I don't really, you know, many people don't appreciate that there's also different room types with a negative pressure and positive pressure. But the point is, it's an aerosolized disease. It's in the air, and you want to keep the air in one area. And we burn through PPE on one patient because that patient needs a lot of care, especially hourly ICU care, right? Yeah. So they talk about, you know, on the news, I think the general public and even physicians, there's so much stuff on social media and the news, this treatment, this, that treatment, that, this is, you know, this is better, this is worth, everybody should be taking some medications. And I think even, you know, it makes everybody crazy trying to figure out these treatments. And I worry to the public that the public, you know, kind of thinks about these treatments so much, but you know, it's not their ballpark to really have to worry about the treatments. I think we physicians have to be up to date on these treatments. But what do you do right now in the ICU for these COVID positive patients?
Yeah, well, I think the first thing to realize, kind of going off what Dr. Valdez had mentioned, is that COVID-19, if they make it to the ICU, they're actually one of the sickest people we're going to have in the ICU. And the reason for that is they usually have a severe lung infection, but the COVID can also affect your heart. It can affect blood clots in your body. It can affect a lot of different things. So COVID-19 patients, when they come to the ICU, unlike a heart attack or a stroke who stay maybe 3 or 4 days, our patients that come to the ICU can stay weeks to a month and may make it and may not, and they could still die. And I think when we think about the treatments for these people, unfortunately with COVID, at least right now, there is no good treatment. We've been looking for medication to control the virus. We've been looking for medication to help the body fight it off. And we're still at the early part of our discovery. I think it's such a new disease that I think as a medical field, we haven't really discovered the treatment yet. So that's what makes it really scary, because when you come to the ICU, all we can really do is help support the body and give the body some time to fight off this infection. And so in the ICU, if you have a severe respiratory infection, as Dr. Valdez mentioned, you may need to go on life support. You may need to go on a breathing machine that breathes for your lungs. And because the amount of support that breathing machine is giving you, we may have to put you in a coma. We may have to make you paralyzed. And all of these treatments will have an effect on your body. It makes your body weaker while your body tries to fight the infection. So there's not really a lot of treatment. That's why it's very important that we stress trying to prevent the spread of COVID, because when you come to the ICU, we can support your body and just hope that you're going to fight off the infection, and then we can help you recover. But there's really no magic bullet. There's no magic remedy. And we're still trying to figure out what those remedies are through science and experimentation. And a lot of the scientific community has probably gotten together worldwide to try to solve this problem, probably more than any other disease in recent history. So we're hoping that they come up with a solution. But for now, when you come to the ICU, we'll support you. We'll put you in life support. We do have some treatments like steroids that might make a difference, but right now there's no good treatment. It's not like having a regular pneumonia where you have an antibiotic that would kill the disease. Unfortunately, we're not there yet.
You know, can you mention other medications that are currently being used for COVID-19 treatment, so people will be familiar if they hear it?
So I think the main one that's out there that works or has some benefit on whether or not you survive is dexamethasone. And what this is, it's a steroid, like similar to prednisone that you take. And basically, of all the studies so far, that's the only one that's has actually some mortality benefit. You might hear the word remdesivir, and that's a medication that's probably works better on Dr. Kline's patients who aren't in the ICU, because it'll help them get out of the hospital faster, but it hasn't really affected how many people live or die from the disease. So they're the first two that are really out there. And then the other thing that's being studied is this concept of people who had COVID and survived, their body built up a resistance. Some people can donate their blood, and we give that blood to people with the disease. And sometimes the resistance you had when you have it, you can give it to somebody else. And that's still being studied. So I think that's definitely something that may work, but we're still trying to figure it out. So
and that's called convalescent plasma, correct? That's the term, convalescent plasma. Okay. Okay. And so I know you guys hate this question, but I keep getting this question. What is proning?
Okay.
I know you hate this question.
Time. Yeah, tummy time.
Tummy time, okay.
That's actually a pretty accurate description, tummy time. So proning is basically just, it's essentially tummy time. You have the patient lie on their stomach, and the whole general, like the easiest way to explain it, this is the way how I explained it when I was a fellow, is basically when you have somebody that's lying flat, the lungs aren't able to expand as well. So you have the weight of the heart, you have the belly, you have the chest muscles all kind of bearing down and preventing the lung from expanding as well as it can be. So in order to relieve that pressure, you flip the patient over onto their tummy, so tummy time or proning. And basically that relieves all that pressure, and then the lung has a better chance of expanding. So mostly the bottom part of the lung will have a better chance of expanding. So the biggest thing is, you know, when you're not that sick and you're like in the med-surg telemetry floor, it's not pretty easy to do. Doctor just goes in, like, hey, why don't you just lie on your tummy for a while? And, you know, it's easy enough. You just kind of flip over, do it yourself. But in the ICU, you're attached to a breathing machine. You're potentially attached to dialysis machine too. You have all these IVs and lines and all these things sticking out of you. And on top of that, you're sedated and you're paralyzed. So obviously you're not going to be able to prone yourself by yourself. So you have a team of nurses, and even the doctor gets in there, and the RTs, the respiratory therapists, all get in there. And that's like at least 6 to 8 people that are in that room exposing themselves to this virus for the purposes of flipping you over onto your belly. So, I mean, it doesn't work for everybody, but that's just kind of the general principle. And it's a pretty labor intensive procedure that we do. And we do that usually in the ICU. We'll put you on your belly for at least 16 hours, and then we kind of flip you back depending on how you're reacting to that treatment.
Because I imagine you burn through, you're telling me 6 to 8 people, you have to take them away from whatever they were doing to help you with this one person. You have to need gowns and gloves and PPEs for all these people which you're going to use. And then your patient is attached to all sorts of things, and which can be dislodged at any given time if a wrong move is made. So it's kind of pretty scary, but thank you for sharing that. Okay, so let's highlight Dr. Kline down here. Okay. Thank you, Dr. Emilio and Dr. Mark, for making our patients better, that they're now out of the ICU. And now they're well enough to get out of the ICU. Dr. Kline, do you want to talk about what a hospitalist is really quick, and then talk about your role in all of this?
Sure. Hi, everyone. Thanks for having me as the token. I really like being here, and I'm very, it pleases me, and I love working in Hawaii. My family brought me here, and I haven't been ever happier. So a hospitalist, I'm kind of a fill-in for your primary care doctor. I work only on people who are admitted into the hospital and are sick enough to be in the hospital. I sometimes will ask for help. I will ask our ICU doctors for help. I will ask a heart doctor for help, a kidney doctor for help, when I try to figure out what is going on with you. Our goal is to get you well enough to go back home. We have different levels in a hospital. Dr. Ganitano and Dr. Valdez already talked about our highest or our sickest area in the hospital, the ICU, but we also have areas like telemetry. Telemetry is where we are constantly monitoring your heart rate, where we're constantly monitoring your breathing at all times. The nurses, even though they're not in the room, you're hooked up to a little machine where somebody is watching it 24 hours a day, 7 days a week. We also have something called med-surg. Med-surg is an area where you're doing pretty darn good. You're just not quite ready to go home yet. Maybe you need an IV medicine for a little while or something like that. We have to manage everybody there. Luckily with COVID right now, we are getting the majority of our patients requiring telemetry and not ICU.
Okay.
We also have resources in telemetry that are running out, just like Ganitano talked about.
Right. Can you explain, you know, we keep hearing on the news too, you know, the hospitals are getting full. The hospital, what exactly does that mean to you?
I think Dr. Ganitano said it absolutely best. It's the amount of supplies that we need, as well as nursing staff that we need. It's the ventilators you'll hear a lot of talk about are machines that will actually breathe for you. Oxygen is what patients with COVID-19 need, and they need it for an extended period of time. There are different ways of supplying the body with oxygen. Sometimes little nose things that go right just in your nose and just give you a little bit of oxygen. Other times there's a forceful device that will force air into your nose. Those are all in short supply. The nasal cannula for the nose, that's okay. But all hospitals have a limited supply of the forceful ones. And that's one of the things that we are worried about getting or running out. And again, the nursing staff, the correctly trained nursing staff is a big thing.
What's the difference? Again, we talked about nursing in the ICU for these COVID patients. How about on the floor? Is it different?
It's a little bit different. You don't have the one-to-one. Usually a COVID patient in the ICU will have one nurse, or one nurse will have two patients max. On telemetry, we've been lucky in Hawaii because we've been doing such a good job. We would say a nurse has about three, sometimes now four patients, because we're starting to get a little whelmed. We are getting 3 to 4 patients, and the nurses are still having to go in each of those rooms at least once an hour to check on the patient, and they are using correct PPE, the exact same PPE that they are using in the ICU, the mask, the eye shields, the gloves, the gowns. And it's difficult, and it's not just the nurses, it's the nurses' aides, it's the respiratory therapists who we absolutely help. It's the doctors ourselves, and we are going in and we're asking them to do tummy time. It's a lot easier for us. I've helped pick a patient up and turn him over on his belly myself, but they're not sedated, they're not knocked out, they're not in a coma.
And then tell me, Dr. Ganitano, Dr. Des painted a picture of, some treatments that we have for COVID patients in the ICU. How about on the floor? So they don't have a ventilator, but what else can you do? And what's the purpose?
We're doing
keeping them in the hospital otherwise.
So that's a very good question. We have the same medicines that Dr. Ganitano alluded to. The steroids, and we've been treating people with pretty hefty doses of steroids. We use the remdesivir, which is a medicine that is something called an antiviral. Maybe you've heard of Tamiflu. Tamiflu is something that they give you to a flu, because flu is a virus as well. Remdesivir is essentially Tamiflu for COVID. I think you already heard that it is not a cure. This doesn't cure it, and it doesn't necessarily save your life. It decreases your symptoms. So if it would normally take you 21 days to get better, it now takes you 14 days to get better. That's a big difference, and a lot less time you need to spend in the hospital, but it's still not a cure. The other one is the convalescent plasma, which is essentially what the ancient Greeks were doing, giving you the blood of somebody else who's already had this and hoping that it works and gets you better. We are doing this here in Hawaii. I've given it to a lot of patients. And you have to agree to take it because it is still a testing medicine, but it has, personally, I think it's doing a really good job.
And then, okay, how do we get patients home? How do we get everybody out of the hospital? How do we get them home?
We're all laughing because that has become a very difficult discussion. Nobody wants to catch this, and I understand that. People who are in the hospital have family members who are at home who are scared to have them come back home. I understand that. And I have nursing facilities where if somebody is maybe a little too weak, maybe they've had a really bad infection, maybe they were with Dr. Valdez for a long period of time in the ICU, they come down to telemetry, then they go to med-surg, they're still too weak to go home. They still need help moving or walking, and they need somebody to cook for them. We tend to get them to a nursing home or a place called a nursing facility. Unfortunately, a lot of nursing facilities don't want to take patients who have COVID because they don't want an outbreak at their facility. What we are using is what the CDC is recommending, saying you are no longer infectious or not. If you are no longer a risk or infectious to anybody else, patients can safely come home or even go to nursing homes. Unfortunately, COVID is taking a really long time to treat. So people are in the hospital for 14 days and they're really weak.
Yeah,
I need some help going places.
Yeah, see, that's how a big drain to the system. So we talked about there's not enough doctors, there may not be enough beds, and the length of stay for these patients are a long time. So it's for them to be in, they're going to be in a long time. So we don't have enough beds for the new patients that came in. And I know numbers for our COVID patients every day are spiking. So the risk of more hospitalizations is very real. I have a question from the audience. I guess it's for all of you. What ages are you taking care of in the ICU and also on the floor or in the hospital?
I'll give Rich a break here for a little bit. Unfortunately, we're seeing all ages, from as young in their 30s all the way to people that are elderly. So it can affect anyone. Fortunately, we haven't seen a lot in the community in terms of young children, but there's definitely been cases on the mainland where younger kids are catching COVID and getting really sick. But for the most part, I would say it's averaging maybe 40s to 80s, I think would be the common ones, but probably the ones who have the hardest time recovering are the elderly and the frail. I think the older patients, especially if they end up in the ICU, have a lot more difficult time surviving that experience than the younger ones. But we have seen, unfortunately, young people die from this. So in the ICU, at least, it kind of affects a wide range of people. So I don't think anyone's truly safe.
Okay. How about you, Dr. Kline?
Just in as much as, I guess I'm confused. Which part that Dr. Ganitano didn't say?
The what ages are being admitted to your floor in the hospital?
I'm seeing the exact same. The population in Hawaii, and it's a curve throughout the United States, is the same. Patients between about the ages of 29 through 65 get this and get hospitalized the most common. Unfortunately, patients over the age of 69 are the ones who are dying the most often. And it is a very cyclical disease. Days 8 through 12 are your worst days. If I can get you through day 12, I'm very happy for you. I'm less worried about you. But if it's day 8 and I'm talking to Emilio or Mark, I'm worried.
And tell me, remind us, why do the older people get sick faster, and why don't they do so well? For all of you guys.
I think generally speaking, the older you get, the more kind of comorbidities you get. So the studies have shown that, you know, people with comorbidities like hypertension, diabetes, obesity, cancer, chronic lung disease, things like that, they just don't tend to fare as well as the ones that don't have any of those things. So it's just unfortunate that the people that have those things just tend to be on the older side. So that's kind of why the older population tends to be more at risk than the younger ones.
I got a question from the audience. Do patients need oxygen to go home?
Sometimes, yes and no. If you have a very good home situation, meaning you have people who can help take care of you, you are not all alone, and you are not just confined to your bed, meaning you're getting up and you're walking around, I will feel safe sending you home with oxygen. I'm not allowed to send you home with a lot of oxygen, but a little bit, and you can take yourself off, absolutely. I will try my best to try to get you home without oxygen, but there are people going home with oxygen.
So does that mean they have to wheel around that oxygen tank and have the thing in your nose? Is that what you're talking about?
Sometimes.
Okay, just clarification. Okay.
Yep. Sometimes there's special new machines that can get it. And you wear it in a backpack.
Yeah. How do you know, another question from the audience, do you know how long it takes people to fully recover, like fully feel good for those patients? You know, you talked about, like, you know, you got out of the hospital finally. How long does it take? Do they feel better from your experience?
So, okay, fair enough. So I've started taking care of patients with COVID since March. This is a new disease. This is not something where we can tell you if you had the flu, you start feeling better after 2 weeks and you're going to be all good in 2 months. We don't know yet for COVID. It's too new. I've had patients who have mild cases and they're admitted to me and I will take care of them for 5 or 7 days. They go home. And because I'm only in a hospital, I don't see them in a clinic as an outpatient as a follow-up, but I've called some and said, how are you doing? They still feel short of breath. So people from March can still feel fairly short of breath. There aren't studies yet. There's going to be one out of England next year who are following 10,000 patients a year later to see how they're doing. But we don't know long-term risks or long-term effects of this yet.
Okay.
And I think it's even more so for patients who are in the intensive care unit, because I think just all the things we do to you to get you to survive COVID can cause you to have a lot of things such as muscle weakness, delirium, and even anxiety and depression. So I think there's a lot of stuff that COVID, not specifically related to COVID, but if you get sick enough from COVID and you end up in the ICU, you can develop things that are now called post-intensive care syndrome that can affect you for years. So I think that's another aspect of this condition. If you're sick, you end up in the ICU for a long time, you're going to get things that people in the ICU unfortunately get. So that adds to the stress of just the COVID itself.
Where are we in Hawaii now with COVID? What do you think? How are we tracking this? How is you as providers keeping informed? And I guess what's the trends that you see? And is the trends that we see on the computer and stuff, is that real?
Yeah,
I think it is.
Yeah, I think so.
Yeah, I think what was interesting was that back in March and April, you know, you put on the news, here's our projection. This is how many people we think are going to get infected. And, you know, as we all remember, this is a line that was straight up, which meant that in a short period of time, we were going to get a lot of infection. And I think what happened at that point back in March and April, everyone kind of panicked and everyone got scared and everyone said, oh, let's do what the government says and just try to do other things for the community to make the curve flat, which you'll hear that term a lot. And we did, the curve flattened. And I think now, mid-July to now, that surge, as they call it, that steep rise in the amount of cases that we were worried about in April is happening now. And that it's, you know, again, today we had over 250 new cases again. So I think we're right in that point where we were afraid of a few months ago. So I think we're not, and to be even more accurate, as Dr. Kline and Dr. Valdez will attest to, is that in all the hospitals we work in, we see a lot more people that are now not only having COVID, but are being admitted to the hospital because they're sick. So I think personally, we're kind of achieved that place that we're afraid of a few months ago.
Okay. So we talked about all this ordeal, how COVID has started to run our life since March. What do you think we've learned? What are some general statements?
I'm guys, I hope you don't mind. I'm going to take this one. This is not a hopeless disease. There is hope. Patients are surviving. I truly, honestly feel patients are surviving with the treatments we're doing now that may not have survived in March. We are learning every day from this. It is incredibly, incredibly important to do what everybody keeps saying to do. Wear masks, social distance. My mom lives up the street from me. My sister-in-law lives down the block. Hawaii, we all love each other. We have Ohana night every Thursday night at my mom's house. We haven't done that since February. We can't congregate in large groups anymore, and it makes me sad. She can't see my baby because we can't be around people like that. But it is not hopeless, and this will end at some point. We're going to figure something out for this thing. But in the meantime, we have to stay vigilant, and we have to do everything we can to avoid this. And we'll take care of you when you come in. But please, please, please do your best to try to stay away from everybody, wear a mask, and do everything they're saying. Wash your hands.
Yeah, I want to echo what Rich says. Basically, the flattening of that curve earlier this year, I think that was a testament to how well just social distancing and wearing your mask and all that stuff. When people like really paid attention and followed the rules, yeah, like we flattened that curve. Like the rest of the country was going crazy, and we were like, hey, we're just sitting here like all lovey-dovey and whatnot. And now that, you know, this with the kind of lackadaisical kind of attitude that we've had more recently, I mean, you're obviously seeing people are like gathering more and all that stuff, and now we're seeing like the effects of it. I mean, our numbers are still like triple digits, you know, it's crazy. So wear your mask, wash your hands, 6 feet, all that stuff.
What should we do? I think there's some confusion of what we should be doing if we think we're exposed or if we think we have COVID. And I try to explain to my family and my friends quarantine, but yet they're still out doing stuff. Can you guys explain what we should do and what does quarantine mean?
Okay, so there's two words that you're going to hear: quarantine and isolation. They are essentially the same thing, but they're different. Well, that doesn't make any sense. Quarantining is for people who do not have any symptoms. They're for people who are feeling absolutely fine, but may have had contact with a positive person. So if you live in a house with somebody who had COVID-19, you are now on what is called quarantine. And there's a particular time frame that you should be on quarantine after your exposure with somebody who has COVID-19. You go to work, you get in contact with somebody, you go home, you are now on quarantine for 14 days. The other word is isolation. Isolation means you actually have COVID-19. You have tested positive, you have the disease, and you now have it. What does it mean when you're on either quarantine or isolation? It means that you need to stay away from everybody. Ideally, you would stay away from everybody, even in your own house. You would be in your own separate room, have your own separate food prep area, or have it delivered to you, as well as your own bathroom. We already talked that this is an aerosolized, meaning anytime you breathe out, this disease can get in the air. So what we want to do is try to avoid you breathing it out on anybody else. If you're on isolation, you need to wear a mask. Almost all times, even in your own house, if there's other family members. If you live alone, probably not. But if you live with people, wear a mask at home. Try to stay away, use a different bathroom, use a different kitchen or a cooking space if possible. On quarantine, that's not as important. You don't necessarily need to wear a mask around everybody in your house. But again, everyone in the house more than likely is on quarantine with you. And that does not mean you're not allowed to go out and shop. You're not allowed to get groceries. You're not allowed to even theoretically go for a drive around the island because you want to just look out the window because you're tired of being home. You're at risk of infecting everybody else.
I'm getting a lot of controversial questions I hope to avoid, but you can't help it. Can we talk about your risk? Somebody had mentioned the difference between high risk, medium risk, moderate risk. Dr. Kline, can you talk about that for a little bit, what that means?
Sure. It's getting back to exactly what Dr. Valdez already said. Do you have comorbidities? Are you somebody, and I don't want to be mean, but some of our comorbidities for COVID-19 are obesity. Having cancer and on chemotherapy is definitely a comorbidity for this, but those aren't the patients who we're seeing routinely who are getting COVID-19. If you are overweight, have high blood pressure, have diabetes, have high cholesterol, those alone are comorbidities. And so that puts you in a high risk. The more of those you have, the higher risk you are. If you're 20 years old and you have no medical problems, you are considered low risk. If you're 79 years old, you have high blood pressure, diabetes, high cholesterol, and maybe you've smoked cigarettes for the past 50 years, you're high risk.
Okay. Well, these are hard questions. Can you get COVID again after being infected and recovering? I don't know the answer. I'm going to give it to you. I
think it kind of ties into what Dr. Kline was saying. Like we're only in this pandemic for like less than a year. We don't know yet, like we don't know if we can get it. It is like, I would guess, yeah, it is possible, but honestly, I think the final answer is we just don't know. It's not enough time has passed to see what the natural history of this disease is going to be. I know there's some like stories of like people getting a PCR negative and getting sent home, and then they get tested again, and then all of a sudden they're positive. Like, does that mean that they were reinfected, or does it mean like it's the test is just reacting to like inert parts of the virus that are still kind of hanging around? Like it's just we don't know if we can get reinfected with this.
I want to jump on that just real quick, only because testing is becoming a question. And again, for family members, when other family members who are positive go home, they have a negative test. You can test positive for this disease for 12 weeks. If I test you once a week, for 12 weeks, you can keep testing positive. Now, the CDC tells us that you are no longer infectious after a period of time. Depending on if you were in the ICU, that period of time is 20 days from your symptoms, when your symptoms first started. If you come into the hospital and don't need the ICU and it's not a critical illness, it's only 10 days. However, you may still test positive for weeks upon weeks after this disease. CDC is fairly certain you are no longer infectious to the rest of your community at all. But again, we don't know if you can catch this disease again. Other diseases you don't routinely catch again, like influenza the same year, the same strain, but we don't know yet. That's why WHO has not made a ruling on that yet. It's just too new.
What do you tell people who can't wear their mask because like they can't breathe? or they feel like it's just they can't do it. And then what do you, and physiologically speaking, like what happens to their oxygen because they're like suffering, they're like smothering their face?
So they've done recent studies just to show people that if you wear the type of mask that we ask the public to wear, that it doesn't affect your oxygen level or your carbon dioxide level. Dr. Ver, you're a surgeon. You wear a mask all day.
I wear a mask all day. I wear stuff all day.
For years, and you don't seem to be brain damage from lack of oxygen or.
No, I get smarter. Masks make you smarter, guys. No, I'm just joking.
So, I mean, I think it's uncomfortable. There's no doubt. Even as a healthcare professional, it's uncomfortable. But then what I usually tell people is it's a lot more comfortable than having a breathing tube down your throat, being stuck on a ventilator, and having to learn how to walk again after being in the ICU for a month. You know, so it's a minor inconvenience, and it's way better than the alternative if you catch COVID. But I think more importantly is what we really know about mask wearing. It's not about protecting yourself, it's protecting the people around you. So I think if you wear a mask, it's for your loved ones, your friends, your colleagues, so that you don't get them infected. Because if you wear a mask, there's a certain level of protection. If you and another person in the room is wearing a mask, that protection is significantly higher for both of you. So it's really not just about taking care of ourselves, it's really taking care of our community. So yes, it's uncomfortable. No, there's no severe negative effects of wearing those masks. And again, it's a lot better than the alternative. So we just got to sacrifice a little for a lot of gain.
Thank you.
I just want to stress that that was a lung doctor who has 3 extra years of training just on people's lungs, saying it does not affect your breathing at all. And my Philly answer for people who ask me that is you can breathe with a mask. What you can't breathe is with COVID. Sorry.
Okay. So we have actually a lot of, really important people watching. Thanks for tuning in. I have candidate for office, Trish La Chica, on, who had a question. There are reports that COVID disproportionately affects Filipinos more compared to others. Is this the same case for Hawaii? And what message do you have for families?
I definitely, from looking at the statistics, it affects Filipino. We're the number 3, I think, in terms of.
We're number 2 now, 2 or 3.
We're up to 2, with the
Maybe.
Pacific Island population unfortunately taking the brunt of this. I definitely think it's out there, so it's really important for us as a community to really try to do those things. But I do recognize that, there's a lot of difficulty doing that, right? There's a lot of reasons why our community has taken the brunt of this. And a lot of it is just really what we do, right? A lot of the people in the hospitals, not only the doctors, nurses, therapists, and even our housekeeping, they're all of Filipino ancestry, because healthcare has been traditionally an area where Filipinos work, in addition to the service industry. So, we're just by the nature of where we work and where we go, we're at a higher risk. In addition, as we mentioned earlier, that we're very social people, and we like spending time with one another, and we like that close contact. And it's very not normal for us to separate ourselves and to be away from our loved ones. And that's the difficulty, because what we need to do as a community so that we don't suffer from COVID-19 is to kind of go against what we always known and what's second nature. So I think continue to love the community you're in and the people in your lives by making the sacrifices to do it, I think is one of the things that we can do as a community. But there's a lot of other barriers too, and I'm sure some of the other speakers can talk about, but it's definitely something that's hit our community very, very hard.
So I wanted to share a little bit from my input also. I was on a World Health Organization and Doctors Without Borders webinar the other day, and they talked about COVID in third world countries. And those third world countries, like Africa, they're very tribal and in their little communities. And really, they don't have much COVID education, number one. And also the role of culture plays a big deal in what people's actions are. So people will say, I will just pray that I don't get COVID, God will save me. And I hear that in the Filipino community too. I'm gonna pray and I won't get COVID. And I think, when I think it's important to stress that we have to acknowledge these cultural differences and these cultural beliefs and try to add on that for change. I acknowledge that you are going to pray. I would like you to pray. Pray for me too, But at the same time, God gave us science, God gave us technology, God gave us doctors who do smart things and smart, safe things. And so if we want to spin the script to, we have to do it for your safety, your family's safety, and the safety of the community. But, you want to try to continue your cultural activities if you're safe. A lot of the COVID spread is at funerals, and I get it. You have to respect the dead. But, I tell patients, we have to respect the living as much as we have to respect our dead, because everything we do today is going to affect tomorrow. There's a question online that talked about how do we disseminate or share information to our ethnic communities? You guys want to take that? We're doing one today, right? Education.
Word of mouth. Word of mouth is going to be a big thing. I think as an organization with Philippine Medical Association of Hawaii, I honestly welcome any feedback from the community of how we can better do this. There's probably a lot of different ways to do it. I know Filipinos, we like to have organizations and everyone's in an organization. So how can we, as the physicians in our community, reach out to your organizations and therefore we can spread the word more. So, I actually want help to do this because I'm not sure how to do it. So we need input and feedback from the community. Do we need to do more meetings like this with different aspects of COVID-19? You want us to speak on your special Zoom meeting? Whatever way, do we need to put ads, put ads in church flyers? Whatever way we can do it, I think is important. And we really got to reach out to the community. And there's going to be the traditional older generation versus the younger generation. And there's going to have to be different ways and different types of media that we need to utilize to get to them. But we really want to spread the message because it affects all of them.
Because how many older Filipinos are looking at their kids' Facebook page right now because they don't have one and they are not social distancing, right? It's
or they're hard. I get a text. They're like, I don't know where the live button is. Yeah. Sorry, Mom. I hope you figured it out. But, if not, I'll give you the.
I checked in with Mom.
I'll give you the recording.
I got the numbers.
This disease.
Go ahead. I'm sorry.
Can I? Sorry. This disease stinks. This is the reason I hate this disease. A lot of diseases, if somebody has a heart attack or a stroke, everybody goes to their bedside and helps them out. The community is there. My Jewish Filipino family here in Hawaii through marriage, that's what we do. We eat. Everybody eats. Everybody goes. Everybody touches. Everybody's around all of the time for people when they're sick. You can't do that. This is the exact opposite that needs to happen for this disease. And it's really, really hard for a lot of cultures. And that's why one of the reasons I hate this disease.
Okay. So the numbers we got that were given to us is Pacific Islander is 31% COVID, and then Filipino is 18%. So we're second. So that's that. Okay. Okay, I want to stop talking about COVID for a little bit, for like 5 seconds, 5 minutes. I want to talk about you guys, right? I feel like, I grew up with a bunch of non-doctors. Before I became a doctor, I had non-doctor friends. Growing up, I didn't have exposure to the medical community. And so people who I grew up with in my family, they still don't know what I do. They still don't understand how my daily life is. I'm going to ask you guys personally as people, why did you choose to become the doctor specialist you are today? What do you like most about your job? And what is the hardest part of your job? Who wants to go first?
I can go first.
Okay.
Wow, why did I become a doctor? Because my mom told me? No, just kidding. It's like the
Living
typical
above
answer. Sorry, Mom.
Okay, that's my answer
No,
too.
but in all honesty,
You know.
I mean, I came from a family where there's a lot of people in the medical field, and I came from a family of teachers, and I came from a family of people who work very well with their hands from all different types of fields. And I think there was one common denominator is that, you know, I came from a family, or I come from a family that works really hard, and they have jobs that they found that were meaningful to them. And for me, when I became a physician, I really wanted to go into a field where my hard work was meaningful, where it would equate into something that made a big difference in somebody's life. And I was fortunate that coming up in my training, I was surrounded with a lot of good role models and a lot of good mentors who really did a really good job at working with people who were the sickest of the sick, the people who were near death, and helping either to fix that problem or helping families when we couldn't fix that problem and helping them to deal with that situation. And I was pretty much inspired by those attendings, and that's why I picked the field that I did. And as I got into the field more, I realized there's so many other aspects of the field that I liked, whether it was the science, working with your hands, you know, working with the leadership aspect, and working with teams and end of life. So there's a lot of different things that through the years I found in my job that I really liked. So it started from one thing. As I grew older, it continued to evolve, and I really enjoy doing my job every day. So I think that's for me why I became an intensive care doctor, because it's meaningful.
What's the hardest part of your job?
The hardest part of my job is, unfortunately, having to tell a family that we don't have anything left to offer, and that it's better for us to stop suffering rather than prolong life. Okay? Getting them to understand that we're not prolonging their life anymore, that we're just extending their suffering. I think that's the hardest part of the job, and that's a very important part of our job, but definitely the hardest thing to deal with every day.
How about you, Mark?
So I'm the opposite of Dr. Ganitano here. So my family is, I'm kind of like more like you, Dr. Ver. It's my family, I'm like the first, I think I'm the only doctor in my family. Yeah, I think I am the only doctor in my family. There's like a couple nurses and like aides in my family, but it was pretty much just, it's just me now. But kind of growing up, I kind of wanted to get a job that was more like kind of helping people. And I felt like I became attracted to kind of like the sciences in general. And medicine naturally came with that. So that's kind of how I got into the whole medicine field thing. It's just kind of helping people with, and I was really good at science too. So that's kind of what led me to my path towards medicine. Surprisingly, so I don't want to out Dr. Ganitano here, but Dr. Ganitano was my teacher when I was a medical student. but he did a really good job. Yeah. So he's
all of our teachers.
Trying to look for a certain field to go into. I really was attracted to the idea of internal medicine because there's so many like different aspects to it that you had to learn, but I didn't really absolutely love one part. Like I didn't love the heart, or I didn't love like the GI system. So I kind of wanted to remain this kind of like general, I need to know everything kind of thing. And on top of that, I actually love doing procedures. I'm really good with my hands. I don't tell a lot of people this, but I used to do like close-up magic type stuff when I was in college. So I work with my hands naturally. So I really wanted to work with my hands with the work that I did. And critical care, which is what me and Dr. Ganitano do, we do a lot of procedures. So that's kind of what attracted me to that. And honestly, Dr. Ganitano and the whole Critical Care Association, that whole group, there's a couple of them that were my teachers when I was a med student. They were like the best teachers I had going through my medical school. So that's kind of what attracted me to the field, and it also brought me back home and to work with them as colleagues this time. So
what's the hardest part of your job?
Oh, I echo
you guys
Dr.
are avoiding the
Ganitano.
question. That's a juicy question.
But I echo Dr. Ganitano, like talking to families and telling them, like, I've done everything I can. They're still not getting better. There's nothing more that we can do. You know, that kind of talk, it's like we do it a lot, and you would think like I would start getting used to it after, I don't know, I've been doing this for like 5 years as an attending, but really like 11 years since I was in training. So I've been doing it for a long time, and it's still super hard. Like there's one recently that hit me like a couple weeks ago where I had to tell the family like pretty unexpectedly, like their loved one was going to die. It was like, I did everything I could. They're still going to die. I can't do anything. And the moment I said the word die, so we were like in this group, like outside the hospital because of the COVID thing, right? So we were outside of the hospital and we were just in this big group. And the moment I said die, I just remember like all of them just dispersing, like they just left me, and I was just like standing there left all alone, like they had just broken up with me or something. You know, it took a lot to kind of swallow, and just kind of stand there and not show much emotion, but just kind of, yeah, just dealing with that stuff is still, we do it a lot, but it's still really hard to do. I don't think I'll ever get used to it, honestly.
How about you, Dr. Kline?
I might be a mix between the two. I come from a family of teachers. Mom's a teacher. My dad is a professor of education of teachers. My aunt's a teacher. Everybody was teachers. We married into a family, and so now there's another doctor in the family. But I originally had no idea what I wanted to do. I actually was planning on becoming a scientist, a PhD. I went actually to Jefferson Medical School with my PhD originally, and I got really bored in a lab. Anybody who's met me knows that I am not somebody who can sit still for a very long period of time. And so I actually left that and became a teacher, and I taught in inner city Philly schools as a high school teacher for about 8 years. I taught biology, chemistry, and anatomy. My best friend from high school, however, became a surgeon. And he said, come on, you really want to do this? You really want to do this? Come on. And so I said, well, let me just take the test and see how it goes. And I did really well. And so I said, well, let me apply and see how it goes. And then I applied and I got in and I said, okay, I'll do this. And one of his surgeon professors actually said, you know, physician actually is Latin for teacher. You are still teaching. And I think that is one of the things that drew me most to becoming a physician, is that, and especially a hospitalist at this point in time, is I am teaching people at a very important part of their life how to get better and what needs to happen so that they can continue to live in some ways. And I think that's important, and I think that's special. So long story short, I went in. I did not become the surgeon my best friend wanted me to, because I wanted a life. I don't know how you do it, Dr. Ver. So I actually did family medicine on the West Coast because I wanted to do everything. I delivered babies. I've performed surgeries. I did ICU care, and here I'm doing hospitals because we do a little bit. We do emergency medicine. We do a little bit of everything. And here, as a hospitalist, I'm really happy because I get to take care of the heart attack, the stroke, and the COVID person. Now, to answer your hard question, what is the hardest part? It is definitely telling the exact same thing that everybody said, that a patient, we've done everything we can, and there's nothing else I can do. Especially now in a time of COVID, where you can't get other people except maybe one or two other people in the room, and even then it might be a stretch. We have kind of closed circuit TVs now where we can have people do a Zoom meeting with their family member as they're dying. I've had to turn on video for a patient dying so that their family members can congregate at home 6 feet apart to stare into a screen telling them goodbye, which in a room that's a negative pressure with 3 fans trying to blow pressure out and getting them to hear, it rips my heart open. And I think it rips everybody's heart open. And it's not why any of us ever went into medicine in the first place. I didn't go into medicine to tell people they're going to die. And it's hard. It's really hard. You think about patients, you remember patients, and you think of your parents when you do that, or I do it anyway. And I have a really tough time with some of them. I really do.
Okay. Well, thank you for sharing that. Back to kind of COVID. COVID, again, has been running our lives since March. And, given everything you told us about, you know, the rewards that we all get from being a physician. Has your outlook changed now that like COVID runs our lives? Silent, think about it for a little bit. Or how has your day changed?
Oh, it stinks. I see the majority of COVID people at the hospital. We have COVID teams where there are certain doctors who see. We are trying to limit doctors seeing COVID people because God forbid we get sick. We don't want everyone to get sick. So I see almost entirely COVID, and which means every single, like my nurses, like not my nurses, the nurses, you have to gown up and glove, and I have to call instead of having a family member at bedside, I have to call every family member, and everybody has a ton of questions. So you go in the room, you see the patient, you come out, you do everything that needs to happen, you talk to your nurse, and then you get on a phone call and try to give some hope to the family members back at home and answer all of their questions as best they can, because they can't see their loved one or be there for their loved one. And that's every single patient. It stinks.
How about the intensivists?
There's definitely a new normal.
Yeah.
In my view, I think one of the things that's palpable in the ICU, working with other people, is there's this sense of almost fear every day you come to work. They're really good people. We're making sure that we're all in protective gear. You try to make sure your teammates are in protective gear. And it's definitely taken away a lot of the personalization of it. Most likely, most of our patients, even if they were awake and alert, have no idea what we look like, because all they see is eyeballs of our masks. And and because the families can't visit, we don't have a connection with them. And I always found that to be a very important part of what we do. So I think it's really changed the way medicine's delivered, but we have to, right? I mean, it's just so dangerous. I don't think my outlook has changed, but definitely feel that there's a lot more added stress, I think, to working in the hospital, because I think everyone's worried about not only themselves, but their family members. We all want to go in and help the patients, but at the same time, you cannot help but have a little concern and fear for yourself and the people around you. I remember especially back in March, I mean, with everything that was going on in New York, you would come to work and you wonder, hey, is everyone here going to be here in 2 months, or is anyone going to get sick? And I still worry about that every day. So for those of you that know me at work, I'm very strict when it comes to people wearing what they're supposed to wear, because I don't want to see them get hurt. I don't want to see their families get hurt. So it's definitely changed a lot the ways we've done things, and it's kind of in some ways depersonalized our experience, right? We don't see each other's faces. We can't eat together on break. You can't congregate because of all the things that are in place, and it's difficult. And I think that's why I really am begging the community to do their part, because I think everybody at work is doing theirs, and we need help. So if they did their part, we wouldn't be as stressed at work doing our part. And we're sacrificing a lot. And we just need people to sacrifice a little, because we all need to get through this together. So that's kind of how it's changed my outlook for it.
I think for me, I'm sorry, go ahead.
Well, I echo everything that Emilio just said, and just to take it to a more personal, for me, it's just, I mean, I have a kid, that's 3 or almost 3, and he sees my mom and dad pretty frequently, and my mom and dad are definitely, they're 70, they have their own comorbidities, so they're part of that high risk that we were talking about. So I always worry about, I go to work, I take care of these COVID patients, I always fear that I'll carry one of those things home and give it to my son, and then my son gives it to my mom. So it's a scary thing. So I've done I used to dress up when I go to work, like Dr. Kline, Dr. Ganitano. No, I used to be one of the more dressed up intensivists. Intensivists usually wear scrubs, but I wear aloha shirt, dress shirts, dress pants. I used to always I've been doing that since, you know, in fellowship, you know, that's how I always was. But with this whole pandemic thing, I can't take that risk. You know, I don't want to risk my parents' lives. So I show up in scrubs now. I change when I'm there. I change before I go home. I sanitize the car before I leave. When I get home, I literally like, I walk inside the door, I strip down all my clothes and I take a shower like right away, you know, all before saying hi to my kid who's like trying to run up and like hug me because daddy's home, you know, like I just don't want to take that risk. And it's a sacrifice, and it's really, it's not for me. It's really just more for my parents and my family. So.
And again, I echo all of you. I think, you know, the COVID pandemic has made me more germaphobe in general. You know, like I don't directly treat COVID patients like you guys, but I am there to support you if you need anything, you know, to help in the hospital, and you guys know that. And the same too, you know, just because I'm in the hospital, it's kind of like you leave the hospital feeling dirty at the end of the day, because you know, like the concept like in the air. So you know, so before I used to, you know, wear my work clothes to work and I'll go to clinic, but now when I get to work, I change into scrubs. I get rid of the scrubs before I come home. I change back into what I came with. You know, I leave my shoes in the hospital. I leave everything in the hospital. So now, like, it just adds extra time, because now I keep everything separate. When I get home, I take a shower right away, or I try to. And now I'm just more paranoid when I go out into public spaces. Like, I don't want to go to the store. I don't want to go to crowds. You know, near where I work is a farmer's market. You know, on Saturdays, it looks really good. And I'm passing by, I was like, oh, too much people, can't go. You know, so it really changes everything and changes your outlook. And also at the same time, being around non-medical people, there's a sort of kind of, you know, distrust that I have around, because I don't know if they completely understand. I don't know if they are taking steps for themselves and their people around them. And so for me to protect me and the patients that I take care of, and for you guys who take care of people in the hospital, like, we just have to take those steps. And it's unfortunate, but it's you know, it's a thing we have to do. So thank you for sharing that. Question I got is, how are you dealing with COVID in your personal lives? And, you know, we talked about a bunch of sacrifices that you're making, but what else are you guys doing to kind of keep you sane?
I now shop at Amazon and buy hand sanitizer.
Yeah.
It's definitely a challenge. I mean, I miss my family. I don't get to see them as much because I don't want to put them at risk, especially if I'm working in a hospital where I'm actually taking care of COVID patients. So I don't get to see my parents, my brother, my sister-in-law, my nephew, and it's definitely depressing. I mean, we keep in touch on the phone and FaceTime, and as much as never the same. So I think it's definitely stressful. You can't do the things you like doing. Like for me, I'm a foodie. I like to eat out. I can't do that anymore. And you know, and you talk to your friends, especially those you see in the hospital, and they're all going through the same thing. In some ways, it's almost good to go to work because you see people. You know, you can actually surround yourself with people because you're all there in full protection. But you can't do that outside of work, right? With the new law, especially with all the new laws and everything. So it's definitely a challenge for sure.
How about you, Mark?
There's a stress.
Yeah, how about you, both of you? What do you do with your kids? Go ahead.
There's a stress. I'm in the same situation as Mark. My daughter's 2, and mom was up the street, and we were always planning on just having my mom is up the street, and we were just going to have grandma take her over or here. And I don't feel comfortable with her touching my daughter anymore. And that's really, really hard for me to say. But I'm scared to death of hurting my mom and my dad with this thing, because I may have carried it home and given it to my daughter, who I'm not so worried about, because kids seem to be doing okay, but God forbid she pass it on to my mom or dad. It's tough. So we come up with things around the house. We come up with things around the yard. Amazon, the blow up pools. running out. We look for buggies. We look for lizards. We turn over all the plant pots and look for things and play with them. We have a swing from the mango tree, and that's what we're doing. We're doing a lot of Zoom calls and FaceTime with the emojis so that she can be a sharky face to talk to grandmom, and that's what we're doing.
Mark, how about you?
Pretty much what I just said. Like, I do try to stay as clean as possible before touching my son so that he doesn't get it and pass it on to my parents. There's a lot of like, there's a lot of like, because we can't go out to like the parks and whatnot. There used to be a park here close to our place where we were able to go when they kind of opened things up a little bit, and we kind of went there. But nowadays with everything closing down again, it's pretty much just like staying home. A lot of like Disney Plus, thank God for Disney Plus and Netflix.
Oh God, yeah.
And Amazon. So there's a lot of like TV watching. And then I've also more recently taken the opportunity to, because he doesn't go to school anymore. Like he used to go to like toddler school. And I feel like that social interaction was, I mean, he only went for like 6 weeks, but his language, like pretty much it advanced pretty quickly. So I feel like he's missing opportunities to kind of grow. So I've kind of taken it upon myself. Me and my wife have been trying to like, get him to, talk more and like get his colors. He's actually been doing pretty good. Like he just recently learned his numbers recently. He knows his colors. He knows shapes of letters amazingly. He's growing, and it's challenging to do it. It's kind of like homeschooling, really. I mean, he's not really in school, but we're making it like kind of a homeschool with lots of Disney Plus kind of sprinkled in there. But yeah.
Mandalorian, right?
Mandalorian. Yeah. I haven't shown him the Star Wars yet. I have to. He'll get to the Star Wars one day. So.
I think too, from my perspective, I worry about education of our future nurses and our future physicians. Medical schools have taken medical students and out of a lot of rotations in the hospital for their safety, but that's how we learn how to be doctors. And so there's a fine line of how do we teach the next generation of physicians, but you guys still keep them safe. My student who I have now, he wants to do surgery and he's not allowed in the operating room. So he's totally like going nuts, and I feel bad and I can't do anything. But, as an educator, we have to do as much as we can to nurse your education as much as we can. So it's difficult. And I think another thing is, there was a question about mental health. No one understands how a healthcare provider or frontline worker feels than another healthcare worker. So I don't mind going to work because I see you guys and you guys got the same angst as I do, and you understand. And, you're going to be respectful of your mask, and I'm going to be respectful for my mask. And so it's pretty, like, even though it's like COVID land, we're pretty safe because we know how each other's feeling. And it's always good to decompress with each other. I often talk to many of my physician friends, in the evening, decompressing about what did you do today? How's your day? How did it get better? Or what can be done better? Because COVID has really changed everything, from the floors in the hospital to surgeries to the ICUs. It's changed everything. Yeah, safe to say. I have a question here. Yes. So definitely this pandemic has made people think about the medical field. Some people are like, oh, hell no, I ain't doing that. I'm not going to put myself in that fire. Or we were actually inspiring a lot of people because they see that we're helping. What do you say to these kids who are considering careers in medicine? Anyone?
I think if your
I
heart
have the
is,
best job in the.
yeah.
Go ahead.
Yeah, I definitely think that if your heart is in it and you want to serve, and that it's something you think you're gonna love doing, then it's a great job, right? So if you love your job, you never work a day in your life, right? Just as the saying goes. So I still think it's worthwhile, but you have to do it for the right reason. So I think if you're willing to work hard and know that it's a job of service and that you have to make some sacrifice, but it's a meaningful job at the end of the day. It's a really great job to have.
Yeah, I
It's
think
the best job ever.
yeah, it's about meaning and purpose, I think. And then everything, little things that you're passionate about in between, you can figure out how to put it in. Yeah, all right. Okay, now I'm getting a lot of COVID questions. What do you wish the community understood? What will your opinions be on how social media and the internet have affected kind of people's perspectives or education? What are your opinions on that?
I think we're in a unprecedented time in the history of the world because information is spread so easily, right? A century ago, when we had the big Spanish flu, you couldn't widely spread information. There was no way. And back then, you would have, people trying to sell their snake oil, which was their remedies for treating that disease. Now, those same salesmen that came up with their own diseases spread it on the internet widely, like ultraviolet rays and stuff like that, hands, like drinking bleach or whatever it was. So, that type of response to this pandemic is still out there, but what's dangerous is that people can spread that all over the internet. So I think as a community, we have to be really careful what we read. Just because someone put it on the internet doesn't mean it's backed by science. So most of the things that we take for granted every day, like for example, taking Tylenol for a headache. People don't realize how much research went into creating Tylenol, testing it out on people, making sure that not only does it work, but that it's safe, and how many thousands of people had to, take Tylenol before we said, hey, everybody, this is a solution. And then, so it takes a lot of science to prove that something works. So when it comes to COVID-19, even doctors who maybe do a study with only 3 people and say, hey, look, if I gave this patient this drug, people got better, but they only studied 3 people. That's not true science, because that could have just been chance. So I think you have to really be careful when you read the internet about and really looking at it and saying, is this really supported by all the science that we've accumulated to this point in the scientific method? Is this really a legitimate treatment? We can't just go because, hey, my friend took this and he got better, so therefore this is not a treatment for COVID-19. Because one, it might make you too confident and therefore not do the things that we ask you to. So for some people, like, if I take this vitamin that so-and-so takes, then I'm not going to get COVID. So I don't need to wear a mask. I don't need to socially distance. And in addition to that behavior, what if the vitamin they gave you is actually dangerous for yourself? So again, there's a lot of rumors out there. I think you should just trust in the people who have spent their lives training to figure out what's the right thing to do and try to take their advice for it, and trust that they have your best interest in mind.
Right. Okay. Anything else you want to tell the community, guys?
I got a text from mom that I'm not allowed to call her grandmom, so I'm sorry. She's too young to be a grandmom. She's Mimi. Sorry, Mimi. You're not grandmom. You're Mimi.
Okay.
Wear your mask, social distance, wash your hands, clean common surfaces frequently. I mean, just stay safe out there. The only way that we're going to get over this is if we all band together and just kind of protect each other. Like, you just take that one person to not do all those things, and then they just go around infecting other people, and then we're right back in the same boat, back in like a lockdown and everything. So we all just kind of have to, as a community, just kind of band together and just do this together. This is the only way that we're going to get out of this, is to just do this whole thing. We're all in this together. Oh God, I'm watching too much Disney Plus. Anyway.
You're right. You're right. I mean, that's
a physician who's watching us has requested that we talk about advanced care directives and PULSed. Can one of you guys explain what that is?
So it's basically a way of letting your loved ones and doctors and lawyers know what your wishes are while you are still of sound mind. So basically it lets you know, like, so the most common situation we use this for is if you have someone who's really sick and you know, their heart's going to stop or they're going to die, basically, would they want the medical team to come in and do chest compressions and try to save their life, or would you want them to just kind of keep you comfortable and let you pass more peacefully? So it's a piece of paper it's a legal document that basically says, hey, this is what I am of sound mind. This is what I want for myself. Please carry this stuff out, kind of thing. And it's actually a really important document, because Dr. Ganitano, and I'm pretty sure Dr. Kline also kind of deals with this a lot, where, you know, we have patients that, you know, they're intubated, they're sedated, they can't let their wants, what they want, be known, because they just can't communicate. So the best thing that we can do as physicians is go to the family and basically say, hey, you guys knew him best. What do you think he would have wanted? And a lot of times it gets misconstrued as, you know, I'm the one that has to make the decision for myself. You know, it's a very challenging place to be in as a family member, to be the one to make the decision for someone else. That piece of paper essentially just absolves you from that, because, like, you can look at the piece of paper and say, like, oh, this is exactly what he would have wanted, so let's do this instead. So it's basically a paper that lets you have a voice when you don't really have a voice.
I think the one thing I'll add to that is, even though you fill out this piece of paper, and the way to fill out this paper is talk to your physician, and your physician will help you fill out this thing called a POLST form, so POLST. So physician order for life-sustaining treatment. So even if you fill out the form though, what I would tell everyone in the audience is make sure you tell your loved ones what you want, because the form itself doesn't guarantee we're gonna do it. So you need to tell your loved ones, hey, this is what I want if this happens. And the second part you also need to think about is figuring out who would speak for you if you can't speak for yourself. So in COVID-19 in particular, you can't breathe, so you can't talk. Or you can't breathe because we have a breathing machine with a tube in your mouth going into your throat because you can't talk. Which one of your loved ones will be the primary person the doctors go to? And again, the whole family can still participate in the decision making, but usually we'll ask for one person that is the one person that I'll call if I have to pick up the phone and say, hey, what does your dad want, or what does your mom want, in case they can't talk? Because we're gonna ask you this when you come to the hospital, so it's good to think about that now, and then to let your family know what you would want. And you know, it's okay if you want everything done. I think that's reasonable for most people, but for some people, they would say, I don't want, if I get sick and I'm on breathing machine for the rest of my life, that's not living for me. Please don't do that. Everyone has a right to say what they want for themselves and alleviate the family's burden of having to guess, as Dr. Valdez mentioned. So I think it's important that when you go to your doctor next, or you do them in telemedicine, ask them, hey, do I have a POLST form? If not, how do I get one done? And then what does this mean? What are my options? And how do I tell my families about that? I think that really helps us take care of you.
I think I wanted to add something too. So it's an important topic to discuss. You guys see patients in the hospital, and if they don't have this paper, you guys talk about it. But for me, who has an outpatient clinic, so I see patients at outpatient, I have the opportunity to talk to them. So for example, primary care providers or your family doctor may refer a patient to me for colon cancer, right? And for this colon cancer, I have to do surgery to take out the colon cancer. So as my own personal rule, I always, for especially my older patients, I always ask, do you have advanced care directives, or do you have POLST? Because during surgery, I'm a good surgeon, but surgery is still surgery and anything can happen. So it gives me the opportunity to talk about, the POLST, advanced care directives, what needs to be done. And we need to sign this paper before I do surgery on you. I think think one of the trickiest things is the cultural aspect of this. In Filipino culture, Polynesian culture, Micronesian culture, we don't talk about death, right? It's bachi. You don't talk about that stuff. If you talk about it, it's going to come to you, right? But I think that's what causes the increase of length of stay in the hospital. That's what leads to stress and confusion in the family. You know, because mama, nana or tata say falls and gets hospitalized, and they never told anybody what their wishes were. So then you got 4 kids in Hawaii arguing with the 4 kids in the Philippines, talking about like what they should do. And then the eldest has to make the decision and has all the guilt, you know, and that's culturally, that's what we do. But it shouldn't have to be that way. All of us have a voice in what we want with our lives, and I think it should be respected. So if you don't have a pulse, even young people like us, we need it. Might get hit by a car right now, knock on wood. You know, anything can happen. And in the era of COVID, where we're talking about, you know, young people and old people can get very sick and we don't know who gets what, it's more important than ever. So please take the time to talk to your loved one about your wishes. If your heart were to stop or you stop breathing, do you want CPR? Do you want full treatment, aggressive surgery, ICU, or do you just want to be like, leave me alone, comfort care? Do you want some, you know, be fed by artificial tubes and things like that? So these are important questions that we should be asking each other now and asking your families now. So if you have parents and you don't know what their wishes are, you ask them today, soon, because you never know. And then if you have a spouse or significant other, you ask them. Because at the end of the day, you're going to be making the decisions, and the decisions shouldn't be your decisions. It should be your loved one's decisions already put on paper. And that's how, you know, the importance of pulse. So that's what I have to say about that. Okay. Well, now I think I covered everything that I wanted to talk about in our session here, but we just got flooded with so many controversial questions on our Facebook chat here. If we will try to answer as much as we can, but again, all these are kind of controversial. I have to say, our opinions are our own, and but we'll try. Okay, so. Question 1 is, what do we want to tell healthcare leaders when we're talking to them about our state and COVID? What are advice we have for them? These are hard questions, guys.
Wow, that's a tough one.
I know.
I mean, I think we need to continue our efforts to increase testing. It's not ideal. But to be honest, Hawaii has it better than most places on the mainland in terms of availability of testing and turnaround time. But I think you really need to ramp up not only the testing, but all the contact tracing so that the tests become meaningful, because we have to tackle this as a community. I still think there's a lot that can be done in terms of organizing the hospitals to work together to take on COVID. I think there's been a lot of cooperation, but that can obviously continue to get better. I think honestly, as unpopular as this is, I think the government does need to think about these limiting risk by decreasing big crowds, for example, but doing it in a way that makes sense and that's backed by science. So I think a lot of that is what the government should continue to look at.
Okay. I think healthcare leaders, I think it's important to talk to doctors and nurses on the front line, because you guys, we are the ones treating COVID directly. We are seeing what's out there. We're boots on the ground. So, you know, a nice check-in here and there would be nice. And seeing what our experience is. I think, you know, medicine is a business also. As a Philippine Medical Association president, you know, a lot of my docs are private practice docs. They need support too, because they are a business. You know, supporting them, supporting mental health for our providers. You know, we are at war right now, and we need as much as mental and social support as somebody else who goes to war. And this COVID is going to be here for a while. How about you guys?
I would agree with that. But I would add on in some ways, this is not just mental health care for workers, but mental health care for everyone. Support would be nice, because this is as much, yeah, and I know that's ideal anyway, but in this case, this is as much a medical disease as it is a social and mental disease, because everyone is frightened to death, sometimes rightfully so, of this disease, and people are scared. And we need the contact tracers to get on board and tell people, you're on quarantine for this date, here's why you're on quarantine, here's what this means. And it needs to happen. I can't have people coming in with their letters saying, look, I'm off quarantine now, and oh yeah, somebody else at home is positive. That's becoming, and I go, well, that doesn't mean you're off quarantine, but that message hasn't been given to them. And translating to all of Hawaii's awesome because we have such a cultural mixture and such a multicultural amount, but we need the translators there to help get the message across to all of the cultures here, and that we need to be safe distancing, that you are on isolation, that you are on quarantine. What does this mean? And providing support for those people. We have great support systems. There's an organization already dropping off pulse oximeters and checking in on people twice a day, but they're getting inundated at this point. And we need people who can do that, who can check in. If your loved one has this, call them on the phone, check in on them. How are they doing? Do they need to come to the hospital or not? Can we get things to their door? Can we get warm food or food that can be reheated so it kills the virus? Please don't drop off cold food that is then going to be consumed at your family's home, so that they don't have to go out. Things like that need to be done. Our leaders need to tell us that.
And I think too, great leaders think like 10 steps ahead, you know, as we all see now, you know, the economic burden of this, but there's also the mental health and the social burden of this. So we should be planning already for what's going to happen. We should have mental health providers lined up, ready to go. You know, we need to figure out what to do with the kids who can't go to school. What's their lives going to be like? You know, we should already start thinking about these questions and making preliminary plans and having teams think of the what ifs, because I feel like, you know, we are very reactive people, meaning something happens, we need to fix it, right? But if we prevent something from happening and we already have a plan in place, that's what I think true leadership is. When you have already thought of every possible thing, every X, Y, and Z, and have a kind of not a 100% plan, but it's somewhere in your thought, I think that's a great way to start. And that's what I would tell my healthcare leaders. Okay, I have State Representative Della Au. Thank you for joining us. She asks, as healthcare providers, what reasons would you advise people to travel out of state, and how important it is to adhere to the 14-day quarantine upon returning from out of state? I don't know if yeah. Should we quarantine when we come back? Or when should people leave to go to mainland for something? And then when they come back, should they quarantine? Is the question I got. That's kind of really common question that I don't know the answer.
I mean, if you talked about today, I would say the only way you should be leaving the state is if there's a life and death situation on the mainland, like you have a loved one that's dying or passing away. This is not the time to go on vacation. You should do as much business as you can without going. I think, at least if the question was about today, there's just too much COVID rise in the community, and I at least to protect us from COVID getting in the state, you have to quarantine when you come back. I don't think there's a better answer for now. You know, I think in the future there may be options regarding more testing and getting cleared to come back, but the way things are today, I would think we still need to quarantine.
I think
I'm probably going to get in trouble. Oh, go ahead.
I
I'll stay out of trouble for a little bit longer.
I think there's, I don't if you can do what you need to do by not leaving the state, then do it that way. I can't really think of a reason to, like, I'm trying to think of like a reason to actually physically leave the state to do something. I feel like, you know, in today's world of like, you know, emails and faxes and all that, and cell phones and all that stuff, I feel like a lot of the things that we need to do, even work, you can do from home through like electronically, you know. I think if really can't think of an example, but if you really didn't need to be there physically, then I guess that would be a reason to leave. But definitely for sure, when you come back, I would say, yeah, 14-day quarantine just to be safe, because I mean, just the risk of spreading it to the community, it just takes one person just to have it and just like, you know, go around breaking quarantine just to spread it around. This thing spreads pretty easily in the community. So 14-day quarantine, I say, yeah, when they come back.
Go ahead, Rich.
Yeah, thanks. I don't mean to be so real. This week, my most recent patient who passed away got COVID from a family member who went to the mainland and came back and quarantined in the same house, which I gave it to their parent, and the parent died. Quarantine, again, I'll allude back to what I said earlier. Quarantine means if you are trying to not have contact with anyone for those 14 days. If you do live in the same house, and we're in Hawaii, we all have multi-generational homes, wear a mask, try to stay in one room, have the food dropped off outside your door, do not participate in cooking food with your family, and try to use a separate bathroom if at all possible. It's super, super important. I'm seeing it. That's how people are getting it. It's, yeah, we have to quarantine, you have to isolate, and you have to do it for as long as the health department says you need to.
And talking about people in the houses, you know, people seem confused and, you know, don't know really what to do with the mandate of only 5 people around. I don't know. What do you guys have to say about that? I think it's difficult to enforce because people here have multi-generational homes.
Yeah.
And they need help. Auntie up the street might need you to help take out the trash for her because she can't carry it out. But
yeah. I think the general concept of just do your best to not expose yourself to people from a lot of different places, right? Because you don't control who they get exposed to. So, I mean, you can have a family of 10 and you all live together, but it's the same 10 all the time. Okay. And they all, you know, they all wear their masks and you do safe habits. That's probably more safe than having 3 people over, or 2 of them, you're not sure who they are and who they hang out with. So it's really just trying to put yourself in a position where you get exposed to the least amount of variables, I guess, the least amount of people you don't know. You know, and I think that's the concept that they were trying to get at. Whether or not the new rules and laws are enforceable or even make sense, I mean, I'll leave that to someone else's opinion. But I think in general, just try to limit how much outside exposure you have among yourself and for your family. I think that's probably the idea they're trying to go for. I would guess.
What is your opinion on opening the state and opening schools and vaccines?
Wow, that's
That's really loaded.
I know, these are hard questions. And thank you, our watchers, because you're really challenging us, because we think about these all the time and we don't have the straightforward answers for you either. But I think we appreciate you being here, and many of you have hung on for the last almost 2 hours. So thank you. It's 2:45 right now. We'll be done in a little bit. Again, vaccines take a long time to make. And a long time to research how to, so typically, you know, vaccines, they take many years to make and many more years to perfect. Perfecta means it has to be tested in phases of per the FDA, and that can take years. And now, because of this COVID pandemic, we are asking our vaccine makers to make a vaccine in months. So they can, but there's going to be a question of how good is it? right? And again, the things we have for COVID, since COVID is so new, we don't know if things really work unless we do it over time. And again, we can have a vaccine. Will it work? Hopefully. But again, I'm not really sure.
And the question with that too is everyone going to take the vaccine?
Right.
Yeah.
You know, how many of the people in the audience always get their flu shot? Are we going to have a different motivation this time around? And we all need to take it if we want it to work. So that's all the questions, you know, in terms of that vaccine, that's another aspect that we have to think about. Are we going to have a vaccine that's safe, that we all trust, and we're all motivated to take? And that, so when you ask when is the vaccine going to come around, that's the things you got to put into the equation.
Okay. Mark, your wife is a pediatrician. Sorry to throw in the bus, Dr. Abinzai, but what is her opinion on schools opening, and what is she telling?
So when I talked to her about it, she's actually pretty apprehensive about it. She's pretty scared because in her own clinic, she's right here. How many of you diagnosed?
Come join us.
Fine. How many of you diagnosed so far? 13. She's diagnosed 13 kids in her clinic. So we were under the impression that this doesn't affect kids, but hey, these kids are actually getting infected with this stuff, and she's already like diagnosed 13. So the whole, opening up the school, that opens up a can of worms. There's always this possibility of transmitting the virus, and like you and me, we're probably easier in terms of like staying 6 feet away from each other, wearing masks, washing our hands. You're talking about like kids doing that stuff? There's no way. Like my kid like loves and hugs and touches everything, puts everything in his mouth. It's hard to actually, police, the actual social distancing. So from a pediatrician standpoint, she feels she's very apprehensive about the state opening up schools and, the risk of it spreading again.
Okay. And do you think we're really gonna shut down again or reopen / shut down?
I think it'll ebb and flow as it goes. Well, it'll just definitely be based on how many cases we get and how stressed the system is. Like if the system gets really stressed, it's under some stress right now, but if it gets like really, really bad where, you get to the point of like New York or Italy or things like that, yeah, you can expect it to shut down. My only thing with, opening up and shutting down is it's a reactionary thing. Like we're reacting to actions that have happened a week or 2 weeks before. It's like we're already like too late, like we're worried about these numbers now. Who knows what it's going to be in a couple of weeks? And then in a couple of weeks, if it's too high, then we shut down. And it's like, well, we should have done that 2 weeks ago. Yeah, we should have done that, before. So I think as this pandemic progresses, we'll see the states or even the country just kind of go through these like open a little bit, close when the numbers come up kind of thing. I think it's the way it's going to be, I think.
Couple more questions. One of the watchers says she knows someone who had COVID twice. Have you gotten experience with that in your patients that you're taking care of?
No.
But and that's gets back to my point. You can test positive for 12 weeks.
But not necessarily.
I don't know if they've had it twice or just tested positive.
Yeah.
A month after they've had it and had maybe something else on top of. They now caught the flu or they caught a cold and they still got tested for COVID again and tested positive again.
Yeah.
You can test positive for COVID for 12 weeks after catching it. That does not mean that you are still contagious. You cannot still infect other people.
I have a watcher that is asymptomatic but wants a COVID test, but their doctor won't give it to them. Why is that?
I guess I'll try to explain it as best as I can. Again, if you think that you have COVID, what you are being told to do is to isolate yourself, or I'm sorry, using the wrong word, quarantine yourself for 14 days. If you are asymptomatic, you can quarantine yourself for 14 days, and if you never have any further exposures to somebody who was positive or any symptoms, you're off and can then get back to our less than 5 people groups. The reason they don't want to just do testing is there was some concern early about running out of supplies. There are places that are doing testing for completely asymptomatic that you don't need a doctor's note for. But what is it? Your negative test doesn't tell you much of anything. You can also have COVID and test negative. The test is approximately 70% at its worst accurate. So your negative test is not your get out of jail free card that I'm off quarantine. If you are on quarantine because you were in contact with somebody who was positive, you can't go out and get a test and say, well, now I'm free. You're not, and you may not test positive for another 4 days. You still have to do the quarantine. So I think that's kind of that's my assumption as to why their doctor doesn't want to order them the test. I hope that made sense.
I'm going to go with the last question. How do you build a connection with someone who has distrust against the medical community? Oh, I can take that one a little bit. Again, a lot of things can be culturally based. You know, we don't, Filipinos, we don't talk about, you know, certain things like death or what to do when things go bad. It's just not part of our culture, and we don't like to talk about those things. And also, there's not enough, you know, Filipino or other ethnicity doctors practicing in Hawaii. And in Hawaii, we do already have a doctor shortage. I think, you know, no matter what race your physician may be, I think physicians should practice culturally sensitive medicine. And again, like I alluded to earlier, we must acknowledge the patient's beliefs, and we have to figure out why they have this mistrust. Right, I see it all the time in my clinics. You know, I deal with all sorts of patients, and I ask them, "What are you doing? What are you doing for this disease?" And it might be totally legit in their culture. Yeah, they take this tea and that tea because that's what their parents did, and it worked for them. But if we're able to understand why they're having mistrust or why they're doing, you know, a certain action, then we can figure out how to, you know, kind of meet halfway. When I have students in my clinic, I told them, you know, now my medical appointments is the art of negotiation, right? Because I can't change your culture. I can't change who you live with, how many people are in your house, you know, who's the cook in your family and what's in your fridge, and what your job is or what you have access to. I personally cannot change that, but I can help you figure out how to make things a little bit doable, help you make things a little bit more safe for you and your family. So if a physician were to approach medicine that way, where they see at least halfway eye to eye with their patient, then I think you build some bond of trust, because the patient is going to be like, hey, they're trying to meet me halfway and try to at least see how I see it. And the way they see it may not be wrong in their eyes, and not completely wrong at all. So that's what I gotta say. Anything else from you guys?
I think the big thing with what you were saying is just have open communication. Like you can't have a connection with somebody that mistrusts medicine if you're not even going to talk to them. So you just got to have, it's going to be a tough conversation, but you just have that conversation and just talk it out, like you were saying. I think that's important.
As the token white guy, we've done horrible things. Medicine has a history of doing horrible things to people. I think it's valid to have some mistrust of a medical community, especially in a time where we're telling you we don't know a lot. This is too new. We don't know a lot. I think it's valid, and I think you can say this. Do not feel upset to tell your doctor, I'm scared, I'm upset, and I don't necessarily trust you. You can say that to us, and I will do everything I can to try to get you to trust me. And you may not entirely 100% trust me, but I would hope that you would let me take care of you, and I will do everything that I can to get you better.
I think
everyone here on this picture will.
I think a lot of the mistrust comes from, you know, when this pandemic first started, we didn't know what the heck was going on. You know, we were throwing all this hydroxychloroquine and all these medicines and all that stuff, and you know, we say one thing one week and then the next week it totally changed. So I have a feeling like a lot of that mistrust in medicine comes from that back and forth that we had in the beginning. But this is, and I guess I want people to understand, like, this is what science is. We unfortunately, we have all these other diseases where we actually had time to kind of like figure out what the best thing is to do for them. But here we're kind of forced to like make decisions now because people were getting sick so fast. So it's just an unfortunate thing that the process of trying to figure out what a disease, like trying to figure out what the treatment for that disease, the best treatment for that disease would be, is just kind of like in the forefront of everything. And that's unfortunate, but that's what it is. And it's up to us to kind of try and make amends with those that distrust us.
I think for me I think it's human nature to learn through experience. And this is such a new thing, right? So a lot of the things we ask people to do from the medical field is asking people to do something that's completely out of their nature. Don't go out with your friends. Don't get in big crowds. Wear a mask. And then you'll have an opposite opinion that might not be medical, might be political, business, whatever, that's on TV saying, no, do this instead. You're always naturally going to gravitate for the thing that's most comfortable. So then when you have all these differing opinions floating around, it's really hard to take the opinion of the guy telling you to change your life. And I think that's where there's a lot of distrust. So then, if everyone was saying, listen to the doctors, maybe there would be more trust in the medical field. But you have people, for whatever reasons, saying, don't do what the doctors say or don't do this. And it really makes it extremely difficult. And, we're at a point in our country where, this is at the forefront, and it's really hindering our response to the pandemic. So I think, how do we build that bridge to let everyone know that not only are we doing no harm, but we're actually have everyone's benefit at the forefront as physicians and in the medical field. So I think that's the challenge that we have. And it is hard to ask people to do something different. Change is hard.
And with that, we would like to thank all of you for viewing in with us. Again, we have to do it for ourselves, your family, and our community. So we hope we can make little changes for the good of everybody. So I want to thank my panel, Drs. Emilio Ganitano, Dr. Mark Valdez, and Dr. Richard Kline, for spending 2 hours of your free Saturday to educate the public on what we do as a frontliner. And we hope, to all of you watching, that we hope that you got a picture of our daily lives and what we worry about. And at the end of the day, we may be doctors, but we are still people with families, and people who care about just not just the families, but also the community. And so thanks, guys. We hope to have another one of these maybe in a few weeks or so, because I think it's very good. Please leave your comments on the Facebook. I'm sorry if we didn't get to everybody at this time. I wanted everybody a plug for visit our website, pmah-hawaii.org, to get contact with us and the other services we offer as an organization. You can visit us on Facebook, Instagram, and also we have a YouTube channel that we figured out. We have a YouTube channel. A special shout out to our partners, the U.S. Census, Filipino Complete Count, Ethnic Education Hawaii, Philippine Consulate General of Honolulu, Filipino Chamber of Commerce, Young Filipino Network, Junior Chamber Hawaii, Olelo, and the representatives and candidates for office who did log in and took the time to watch us. And lastly, Hawaii Pacific Health. I have to plug you because you're nice to me and gave me permission to do this. And so thank you, and enjoy the rest of your Saturday. Please be safe. Aloha, everybody. Thanks.